Good morning, good afternoon. From my side, I'm speaking from Germany, from Heugberg, from the Jaeger company. And I'm delighted to introduce to you Professor Alberto Neder from Kingston University, Canada, as the distinguished expert on and author of many publications in respiratory physiology. I'm very pleased that Professor Neder accepted the invitation to speak about the topic of dynamic volumes measured during cardiopulmonary exercise testing, and his insights will help us better to distinguish between excessive and constrained ventilation, a crucial aspect of understanding respiratory health. Before I give the word to Alberto Neder, I think there will be a very short poll with 4 yes-no questions. Please answer them very quickly, so then Alberto Neder, Professor Neder, can take over and start his lecture.
You can start. Thank you very much, Herman. Thank you, everyone. So I think you are seeing some questions. Please answer them. Great. It's a great pleasure to be here. And actually, I should congratulate Jaeger for this very important initiative. We're going to talk about something just crucial to interpret cardiopulmonary exercise testing. You, like me, probably is interested in knowing if the patient has shortness of breath and why that person has shortness of breath. Hope you appreciate over the next 30 to 40 minutes how crucial is to make those measurements. Otherwise, you miss a lot about the clinical usefulness of CPAT. So this is a disclaimer. I have no specific conflict of interest beyond the fact that I just love clinical physiology. So my talk will go over 3 different aspects. First of all, I wanted to put us on the same page, and you are going to see why bother assessing exercise flow volume loop and the lung volumes during exercise. Why wasting time, spending time on that is so important clinically. How should this be done properly? So I will outline the do's and don'ts, very detailed, how to do this measurement. A lot of people don't do this right. A lot of people don't analyze this right. So we are going to see what should be done and should not be done. And I will give you a map on how to incorporate these aspects on clinical decision making based on clinical case. So let's start from really the very beginning. Why people feel shortness of breath? When we do exercise, our brain receives information from the muscles, from the heart, and from the lungs. They feed the respiratory center in the brainstem. We respond to that information by sending a drive to the muscles of movement in the legs and the muscles of breathing. We call this drive to breathe. This is the will to breathe. So our brain, our cortex, receive a copy of this drive to breathe. The higher the drive to breathe, the more conscious you are that you are breathing, and more you have shortness of breath. So at the very end, shortness of breath is the fact that you become more conscious that you need to breathe, which should be something that you are not aware of. So shortness of breath, it's amazing that everything that we discuss in physiology can be simplified in 2 small things. One is you feel short of breath if there is too much air that you are breathing relative to your maximum capacity. Let's call this excessive breathing. The other point is we feel short of breath if the chest wall and the lungs displacement are too big, too large relative to our capacity. So we are constrained in our ability to expand your lungs and chest wall. So wherever you are, Exercise, sleep, ICU, whatever. Always think about that. Shortness of breath is excessive breathing and or constrained breathing. At the very end, shortness of breath arrives when you have a mismatch between demand and capacity. If we ventilate too much relative to the ventilatory capacity, there is this mismatch and you feel short of breath. If the displaced volume of the lungs and the chest wall is too large relative to the limits of that expansion, you feel short of breath. So demand capacity balance. This should always be on our mind when we interpret CPAT. Not only what we are going to discuss today, but other variables as well. So let's think a little bit more on how can we show this during exercise, during cardiopulmonary exercise testing. You know everything this, but I'm just putting you on the same page. Imagine that you have too much stimulation to the ventilation. So there is too much ventilation relative to the carbon dioxide output. Let's call the VE-VCO2 relationship. VE is ventilation, the symbol for ventilation. So you are ventilating too much. That could be hypoxemia, that could be a high dead space, a high afferent stimuli from the cardiovascular system, does not matter. You have too much ventilation. In response to that, you have a high drive. So you have excessive breathing. You want to breathe, I can breathe, so I will breathe. So that means that the high drive to breathe is translated into higher ventilation. Here is the normal dyspnea that we have developed throughout exercise as a function of ventilation. In this subject, because the mechanical pump is not impaired, this patient can translate this will to breathe in higher ventilation. So when we express dyspnea as a function of work rate, it's high. But dyspnea as against of ventilation is normal because he can translate this to higher ventilation. Now let's see the other side of the coin. This individual here has mechanical constraints. His tidal volume cannot expand properly within the limits imposed by the inspiratory capacity. We're going to come back several times on the importance of inspiratory capacity. This is the room to breathe. So the subject is mechanically constrained. So that subject wanted to breathe, but he can't breathe. So what means that dyspnea will be higher as a function of work rate and also higher as a function of ventilation because the patient cannot translate that will to breathe in the mechanical act of breathing. So pay attention, excessive breathing and constrained breathing. Excessive breathing you can measure using other variables on CPAT, like the ventilation against VCO2 and so on. The only way for you to measure mechanical constraints is doing what we are going to discuss today. If you don't learn well about that, you are going to miss and make big mistakes on interpreting CPAT. So you are prone to make big mistakes if you just don't assess how constrained or how free are the lungs to expand during exercise. Actually, this is why you are doing the test, right? You are trying to see if the dyspnea is caused by the lungs. I believe most of you are on the respiratory side. So why bother assessing this, what we're going to discuss today? Because this is the only way that we will have to actually show if there is constrained breathing or not. There is no other way. It's just that way that we should use. So how should this be done properly? Let's start from the beginning in healthy individuals. What you have here is the maximum flow volume loop in someone normal. This is the tidal flow volume loop. Here is the end expiratory lung volume. This is more or less like the functional residual capacity, more or less, not the same. This is the end inspiratory lung volume, so this is the tidal volume. That critical space, let's call this the gold space. You are going to understand why this is a gold space. The name is inspiratory reserve volume. It's the difference between the end inspiratory lung volume and the total lung capacity. You are going to see how critical and how clinically important is this inspiratory reserve volume. This is here is total lung capacity, and this is residual volume. During exercise, here we are breathing on tidal volume, have a full breath in and relax. So we can detect tidal volume, we can detect here the end inspiratory lung volume, the end expiratory lung volume. This difference, it will be a tidal volume, and the difference between end inspiratory lung volume and total lung capacity is the inspiratory reserve volume. So first, let's appreciate how looks like the tidal flow volume loop during exercise. This is at rest in blue and in green during exercise. First thing to look here, even at peak exercise, that loop here, which is the maximal at maximal exercise, does not usually, not always, reach the maximum flow volume loop. If that reach, that it touches the maximum flow volume loop just a little bit, like less than 25%. Actually, this is a very good evidence that the lungs usually don't limit us during exercise. Another important thing is that exercise tidal flow volume loop looks like a bigger version of the resting flow volume loop. Now come a very important point. Please pay attention on this. The system must, I will try to repeat, must have a point to actually detect how the system can plot the tidal flow, the exercise flow volume loop inside the maximum loop. If there is no point of reference, the system can plot here, can plot here, can plot here, whatever, because there is no point of reference. He needs to know which lung volumes is doing. So the only way to do this is to do an inspiratory capacity. When you do an inspiratory capacity, your machine subtracts total lung capacity from inspiratory capacity and detect where is the end expiratory lung volume. By knowing where is the end expiratory lung volume, now the system can plot the exercise flow volume loop inside the maximum flow volume loop. Pay attention on that. If you don't do that, everything is wrong. You can stop analyzing this data. Should be done through a proper inspiratory capacity to plot the exercise flow volume loop inside this specific loop. In the Sentry suite, that the system from Jaeger, this is also done for sure, of course. So you see here, this is a screenshot. This is the maximum flow volume loop. This is the exercise flow volume loop. Look here, how it touches just a little bit, because it's a normal subject, the maximum flow volume loop. And here, the end expiratory lung volume in this specific system is a summation of the expiratory reserve volume and the residual volume. In any case, it's crucial to do the inspiratory capacity. Very important point. The Sentry suite, the Jaeger system, will select the residual volume to put the flow volume loop based on the body box measurement. If this is not done or done for any other technique, they are going to use the predicted residual volume. Be very careful on that, because if you have someone with gas trapping, with a high residual volume, using the predicted residual volume might make you to do mistakes. It's better to actually do the measurement of residual volume. So now let's see how the operating lung volumes do during exercise. So this is someone doing exercise. This is a tidal volume, and this is the inspiratory capacity. Pay attention that the end expiratory lung volumes goes down during exercise. This is because we recruit the abdominal expiratory muscles, and the end expiratory lung volumes goes up. But we always, our brain protect the inspiratory reserve volume. You are going to understand why this is the gold area in a few slides. In any case, if you are breathing on these lung volumes, you are on the most compliant part of the pressure-volume relationship of the respiratory system. No physiology here, very simple. It's just the fact that you are breathing at medium lung volumes. It's very easy to distend your lungs because you are not hyperinflated. If you are hyperinflated, it's difficult to further inflate something that's almost full. But not the case here. You are breathing at normal lung volumes in the middle of that pressure-volume relationship. So a little bit of change in pressure, good change in volume, the brain is rewarded, no shortness of breath. So because there is no expiratory flow limitation, the subject can get rid of the air that he or she inspirate. He can expirate this because there is no expiratory flow limitation. This is normal lungs. So this allows us to decrease the end expiratory lung volume, opening space for tidal volume, give you room to expand your tidal volume nicely. And the brain is rewarded. So there is no shortness of breath. You are going to see how that is different in disease. Let's start from the worst scenario, which is someone with COPD. So this is a normal subject, you appreciate here. But look here what happened in a patient with COPD. The tidal flow volume loop touches the maximum flow volume loop for quite a while. Importantly, the end expiratory lung volumes goes up, not down. Look here, this is rest, exercise. Rest, exercise. So there was a shift of the end expiratory lung volume to the left, so the patient trapped air in the lungs, because it has expiratory flow limitation, cannot get rid of the air that it inspirated. And importantly, the inspiratory reserve volume, look how small is here compared to here. So it means that this person is breathing too high, too close to the ceiling. And that point is difficult to further inflate a balloon that's almost full. And that causes you shortness of breath. Very interesting point people sometimes asked me. But look, sometimes in my system, the flow volume loop during exercise goes over the maximum flow volume loop. How comes if this is the maximum? Well, this is because this is not truly the maximum, to be honest. Because when we do the expiratory maneuver during FVC, we compress the small airways. So we underestimate the flows for that volume. So don't think that is a problem in your system. The problem is that in subjects that have airflow obstruction, the maximum flow volume loop usually underestimate the maximal flow reserves. But in any case, what is important that if the exercise flow volume loop reaches or actually overcomes the maximal flow volume loop. Now let's go at the lung volumes in someone that the stereotype that I think you have on your mind. This is a patient with COPD. So this patient hyperinflated during exercise. This is the end expiratory lung volumes going up, not down. What up? Because he is unable to expire what he's inspired, so it traps more air. But this is not the most important point. The most important point is not the floor, it's the distance from the ceiling. So you see here that the end inspiratory lung volume reaches or gets really too close of the ceiling, which is the total lung capacity. That is what causes dyspnea. Dyspnea is not caused by dynamic hyperinflation per se. It's caused by how close you are from the ceiling. So when you have this, you are too close of the total lung capacity, look here on the right, you are on the less compliant portion of the pressure volume, so you need a big change in pressure for a small change in volume. The brain is not happy at all, is not rewarded, and you feel shortness of breath. So how to detect that? As you saw, this is detected by the decrease in inspiratory capacity. Fortunately, total lung capacity, the ceiling does not change much during exercise. It helps us a lot. So that decrease in inspiratory capacity has only one explanation. The floor has gone up. There is dynamic hyperinflation in this case. So we can follow, for example, in this case, look here, the inspiratory capacity during exercise, going down, at rest, and during exercise in a patient with COPD. See the big decrease in inspiratory capacity. I'm going to provide you with numbers. I know that you like numbers and cutoffs. Wait a little bit. I'm going to show you and give you numbers for you to quantify the severity and the presence of dynamic hyperinflation. But in this case, there was dynamic hyperinflation, right? So to put you more in keeping with actually what happened in both obstructive and restrictive lung disease. Let's again come back to the normal individual, okay? So tidal volume during exercise and expiratory lung volume going down. So opening space for tidal volume. The subject is breathing at most compliant, more linear part of the pressure-volume relationship. You have a good reserve on inspiratory reserve volume. So there is no inspiratory constraints, no dyspnea. Look here in COPD. Again, dynamic hyperinflation, the inspiratory reserve volume is reduced. The patient breathes here at high lung volumes where it is less compliant. The inspiratory reserve volume get lower. So the problem here is the floor. The floor, the end expiratory lung volume went up. Just to be very clear to you again, because there is substantial expiratory flow limitation, air is trapped in the lungs in obstructive diseases. Thus, the end expiratory lung volume increases and the IC decreases. If the floor goes up and the ceiling is fixed, of course, the difference in inspiratory capacity will go down. So the tidal volume becomes constrained on that small space. The brain is not rewarded and causes shortness of breath. Now look at the other side of the coin that people fail to appreciate frequently. That person here has interstitial lung disease. There is no expiratory flow limitation, but he or she is suffering the same thing of the other patient. Why? Because the problem here is even if the patient is able to decrease the end expiratory lung volume, the total lung capacity, the ceiling, is too low. So the difference between end inspiratory lung volume and the lower ceiling will be lower as the other patient with COPD. The same thing happened, breathing at less compliant portion of the pressure volume, the inspiratory reserve volume will be reduced. So it's amazing that people with completely different diseases will have the same mechanism. Again, inspiratory constraints, critical inspiratory constraints. What critical? That inspiratory constraints that cause dyspnea. So in restrictive lung disease, there is little expiratory flow limitation. The problem is not air trapping, is not dynamic hyperinflation. So even if the patient can decrease the end expiratory lung volume, TLC is too low. So IC fails to increase. So again, everything happened as in a person with COPD. Now I wanted you to please pay attention to this slide. Wherever I give talks, people always think about dynamic hyperinflation. I think there is a little bit of a fetish on dynamic hyperinflation. People think, oh, if there is no dynamic hyperinflation, there is no problem. This is a big, big mistake. Look here in these individuals here. On the left, you have a normal individual, and the expiratory lung volume goes down, and the inspiratory lung volume goes up. You have an inspiratory reserve volume. So there is no dyspnea. Here we have an individual that has dynamic hyperinflation and the patient reach critical inspiratory constraints. This is what you always think that's the case. So you have dyspnea. But look at this case here. Actually, in this individual here, there is no dynamic hyperinflation at all. But because the patient started at the higher lung volumes, he also reached the inspiratory constraints and may have even more dyspnea than that guy that has dynamic hyperinflation. The other side of the coin, look at this individual here. This individual has dynamic hyperinflation, but because he's a safe distance from total lung capacity, there is not a lot of dyspnea. So, again, dynamic hyperinflation in this case was not associated with dyspnea. Hopefully, you understand after those 10 minutes of discussion about that what is important is not the floor, is the ceiling. It's the distance that you are from total lung capacity, not exactly if your end expiratory lung volume goes up or not. It's the distance of the end inspiratory lung volume from total lung capacity. Now, let's go to the practical part. There's a lot of science and tricks in doing a proper inspiratory capacity. I'm amazing to see how badly this is done throughout the world. I think people underestimate how to teach the patient and how to analyze this properly. I'm gonna go quickly after 10 or 15 minutes about the technique, but you are invited to read these papers. There we explain in many, many pages every single tricks and hints about that. You are invited to look at these papers. First of thing, please describe to the patient what is the inspiratory capacity. You need to say that during the resting, you are going to see a video in a few minutes, you explain to the patient what is the inspiratory capacity maneuver. If you don't do that, forget. Because you are going to surprise the patient by saying, have a full breath in at some point, and it's not going to work at all. So you need to explain, and you need to do some 2 or 3 rehearsals before that. You should demonstrate the IC maneuver, and this is a very important trick that few people knows about that. Pay attention. Is the fact that in many individuals there is anticipatory changes. The patient knows that he's going to do the IC, so he changed the breathing pattern. So there are 3 ways that I suggest you to teach the patient, or actually tell the patient how to do the IC during exercise. If you note on these rehearsals that the patient does not tend to do any anticipatory changes, you just say, at the end of a normal breath out, take a deep breath in all the way up, you are completely full, and relax. Say and relax. Otherwise, the patient will do a forced expiration thinking that this is spirometry. If you note that there is some degree of anticipatory, you can say, at the end of this next breath, take a deep breath in all the way in and relax. Many times you need to go to this third one. I do this very frequently. This is the fact when there is a lot of anticipatory, you change the breathing pattern, you follow the breathing pattern, and when the patient is at the end expiration, you say all of a sudden, have a full breath in, and relax. That works better, but you need yourself to follow that. Repeat resting IC measurement is very important. That should be done at least 2 or 3 times, so in such a way that the subject is okay at rest. And you should give verbal encouragement during that. You are going to see in a few moments.
So during the resting period and during every stage of exercise, we are going to ask you to take a deep breath all the way in until you're completely full. You will do this from the end of a normal breath out and breathe in without hesitation as quickly as possible until you are completely full. Once you feel that you cannot get any more air in, then you can go back to normal breathing. Does this make sense?
Yes.
So let's do some rehearsals. So from the end of a normal breath out, take a deep breath all the way until you're completely full. In, and when you're full, back to normal breathing. Excellent, good job. Let's try one more time, okay? We'll take a couple of normal breaths, and then when you feel that you're ready, from the end of a normal breath out, take a deep breath all the way until you're completely full. In, and back to normal breathing, good. All right, so as I mentioned, we are going to be doing those deep breaths in every 2 minutes during exercise. But remember, the goal for this test is for you to go as long as you possibly can and exercise until you think that you absolutely can't go any longer. When you think that you're very close to the end, don't stop right away. Give us a signal by waving your hand, and we will do one last deep breath in, and then we will put you into recovery and allow you to cool down. Okay?
Yes.
All right, John, when you're ready, from the end of a normal breath out, take a deep breath all the way in until you're completely full. In, good. Back to normal breathing, excellent. All right, keep it up. All right, John, from the end of your next breath out, take a deep breath all the way in, back to normal breathing, good. All right, and In. Good. Back to normal breathing. You're doing great. Keep going. I think you still have a little bit more there. Remember to give us a signal when you're about 10 seconds from the end, John. All right, keep going for a little bit longer just until we can get this last maneuver. When you can, deep breath in. In. Back to normal breathing. Excellent. All right, I'm dropping the load now.
That's a very important point. Please pay attention on that. We are selecting and change the end expiratory lung volume line in such a way that we can go through the most representative line that goes on the end expiratory lung volume. You should do this on every single maneuver in such a way that you have a representative end expiratory lung volume. I'm going to discuss this a little bit later. This is a very important point to define actually what is the end expiratory lung volume. I'm going to be back to this video later. Although it's true that the peak, very important point. Did you see that my colleague asked the patient to raise the hand and actually do the maximum inspiratory capacity at the end? Pay attention. I see several talks. People say, oh, you just needed to do the last inspiratory capacity at the end of exercise. Don't do that. Because at the very end, I don't know if you noticed, the last inspiratory capacity of this subject was much lower than the other ones, because it's more difficult to do the IC at peak exercise. Please don't do that. Don't just measure IC at the end of exercise. So this is more likely to give you a wrong impression that you have hyperinflated. So it's better to do multiple inspiratory capacity. The more you have, you are going to see, I will give you some suggestions. So it's very important that you pay attention that this should be analyzed as a video, as a film, not a picture only at the end. So some tricks. Do your best to get an excellent IC dynamic, IC during exercise at rest, at least 2 or 3 times, and at every stage during exercise. For example, if you do every minute or every 2 minutes, and if you are doing a ramp exercise, you can do it every minute. I prefer to do steps of 1 or 2 minutes. I like the 2 minutes steps, and we do at the last 30 seconds. Give us more points to analyze. The more points you have, the better. So it's always another very important trick. Always ask Borg dyspnea score before the IC maneuver. Every human being is going to rate dyspnea more intense if you ask this after the inspiratory capacity. Now let's look at how to record the right data. This is the screen of the Sentry Suite system. So this is volume against time. So this is tidal volume, and this is the inspiratory capacity. One very important point is that you have to have 4 to 5 breaths before the IC in such a way that you can put a line through the best representative line. Don't expect, please, that you are going to have exactly the end expiratory lung volume. No human being is a machine. There is some variability, but you need to put the best representative line, and you see that the software allows you to ensure that. It's also important sometimes to have at least 2 breaths after you have done the IC that you may later help you to deal with what we call drift. I will explain this perhaps later. By default, pay attention now, by default, the Sentry Suite, we consider the tidal volume to compare with the inspiratory capacity 2 tidal volumes before the IC. This is to avoid, for example, in this case, that you have anticipatory change. So if you select this tidal volume here, you'll be overestimate the inspiratory reserve volume, right? Because it's the difference from here to here. So you should select. So the red loop is there as a template. So there is a sequence that the software consider, but I strongly encourage you to to open the system, you are going to see on the edit, and select the best tidal volume that is representative to compare with the inspiratory capacity. Another very important point, sometimes the system, like for example in this case, choose the wrong one. Why? Because the default is 2 breaths, right, before. But look here, this tidal breath is completely wrong. It's too small. So you came here, you probably are familiar with the software. You press here on the right button and you select the tidal volume that is more representative of the patient's breathing pattern. Now come probably the most critical thing that you can imagine about this. If you don't make your maximum flow volume loop reach the maximum inspiration, everything will be wrong. Because you, as I mentioned to you before, this is the point of reference of the system. And many times the system does not do that for you automatically. So you need to come here and press on this left button here, and this will move the maximum flow volume loop to match at the end inspiratory lung volume. For example, look here. This is the maximum flow volume loop where the system put it wrongly. But now you come here, you press this button here, the leftward one, and it will put the tidal flow, the inspiratory capacity maneuver on the maximum flow volume loop. We will actually anchor everything to the right volume. So if you don't do that, forget. You'll be completely wrong. So this you need to review on every maneuver that you are going to interpret the inspiratory capacity. So completely wrong data will be recorded if you do not anchor the end of the IC. The other important point that you need to select after that, the end expiratory lung volume line, that sometimes needs to change a little bit here in such a way that you can for yourself see the best line. So after that, the system will plot for you the tidal flow volume loop inside the maximum flow volume loop, and also it to show you that there is 4 selected. You have a maximum of, in the current version of the software, 4 flow volume loops or tidal volumes to plot during exercise. So, and that gives you the tidal volume. This is the total lung capacity. This is the inspiratory reserve volume. And the inspiratory reserve volume is here. There is some numerical data and graphical data. So what are the problems? There are many potential problems. Some of them are related to volume drift, sometimes not well explained maneuver. For example, this is a good one where you have a good inspiration and you have up to the total lung capacity. Look here, this is a patient with COPD. Look how much he hyperinflated, and there is the expiratory flow limitation. In this case, it's wrong. Look here, the system actually underestimated because it put a line based on the pre-tidal volume, which there was some anticipatory change. So you needed to come there and change the end expiratory lung volume line. This is almost impossible. You didn't wait for having several breaths, at least 3 to 4 or 4 to 5 breaths, so you cannot do nothing. And here you have the volume drift. You see here, the end expiratory lung volumes goes up, 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 up as exercise goes. This could be air leaking, or this could be some issues on drift, on temperature and humidity. I may discuss with you later on the Q&A part how you can still use this kind of data. So how to interpret the data? That's the key point, right? So what you have here, all the 33 variables that the Sentry Suite offers to you. What you are going to use is just 6 of them. So you are going to use to detect the critical inspiratory constraints. And now you know everything, right? You know these variables. You are going to use the inspiratory reserve volume. You are going to use the end inspiratory lung volume as % of total lung capacity. as an index of inspiratory constraints, the tidal volume as a fraction of the inspiratory capacity. And you are going to use the end inspiratory lung volume. Very useful graph to plot tidal volume against work rate or exercise duration, and a very important plot to plot dyspnea against ventilation and dyspnea against work rate. With that, you have everything that you need to identify the critical inspiratory constraints. It's a little bit like the ventilatory threshold, the anaerobic threshold. You are detecting here the dyspnea threshold. So now, how to show the dynamic hyperinflation? By looking at the IC dynamic and the end expiratory lung volume. And this is what you need, right? What you want. These are the numbers that you like to remember. Critical inspiratory constraints are reached when the end inspiratory lung volume is at 90% or higher of total lung capacity. Tidal volume is 80% or higher than your inspiratory capacity. The inspiratory reserve volume is less than 500 ml. I don't like that too much because that depends on the size of the lungs. I don't like that too much. Better is these ratios and the inspiratory lung volume TLC and VTIC. And that point is associated with the VT plateau and an inflection of dyspnea. What is the significant dynamic hyperinflation? There is some variability in literature, decrease less than 150, but probably more robust, decrease in 200 ml, or 10 to 15% from the baseline, whichever is lower. And that are the metrics for a tidal volume. Please note that this presentation will be available for you in the future. You can get this from my slides later. Pay attention on that. A completely normal subject can reach these thresholds just because the lungs start to become the limiting step. That does not mean that the subject is a patient. Just means that your patient the subject is well trained and reach this critical inspiratory constraint. So this is not always disease. You can reach that, but that on a supra-maximum work rate when your lungs are maximum exhausted. I will finish in 5 minutes or so, just to put a very clear point on your mind. I know that you that work with CPAP, you are going to ask me, but look, I always learn that there is something called breathing reserve. Ventilation at peak divided by MVV, and if this is low, the lungs limit the patient. If not, the lungs don't limit the patient. Big mistake. So you are going to make big mistake if you rely only on the peak breathing reserve. For example, this is a subject, look here, the subject has a lot of ventilation throughout exercise, but he stops exercise here with a good breathing reserve. Because he had dyspnea, the breathing reserve is preserved more than 15%. The peak ventilation over MVV is less than 0.8 or 0.85. You'd say, oh, there is nothing here, nothing abnormal here. The lungs are not limiting. Big mistake. Look here what happened in this individual. IC decreased, dynamic hyperinflation, a big decrease in inspiratory reserve volume, a plateau on tidal volume, and the expiratory flow limitation. Everything will be completely wrong if you just rely on the peak breathing reserve. So the peak breathing reserve is a very complex and difficult to analyze variable because it's effort dependent and very important. Now you are prepared to understand that. Exactly because you cannot breathe properly, because you are mechanically constrained, you may stop exercise with ventilation well below the MVV, just because you are limited mechanically. And the peak breathing reserve will be normal, and you are going to make big mistakes. And the other side of the coin is also very important. Some subjects are fit, they can reach no peak breathing reserve because they could go very long on exercise, and you'd say that it is a disease. No, this is not a disease. This is the fact that the subject was able to exercise maximally and actually exhaust the ventilation reserves. A quick case just for you to highlight. This is a true life case. Is a patient with COPD, mild airflow obstruction. He has a number of comorbidities, hypertension, coronary artery disease, diastolic dysfunction, diabetes, rheumatoid arthritis, chronic kidney disease, depression. So everything could cause dyspnea in this individual. He was sent to our lab because this dyspnea was out of proportion of FEV1 of only 73% predicted, and the respirologist, the pulmonologist said, oh, this is probably your heart, it's not your lungs. So what happened here? First thing, look here, this is the breathing reserve, the VEMVV, this is the opposite. So it's going down, down, down here. So the patient stopped exercise with VMVV of 0.7. So peak breathing reserve is preserved. So based on this criteria, no problem in the lungs, no ventilatory limitation. VVCO2 is normal. You can see the Neder is also normal, the slope is normal. So if you stop here, this is what the textbook tell you. You stop here, the lungs are not involved. But look the mistakes that you are going to do. The inspiratory capacity goes down dramatically. The tidal volume goes up and reaches the critical inspiratory constraints. The inspiratory reserve volume goes down and reaches the critical inspiratory constraints. The end inspiratory lung volume goes up and reaches close to total lung capacity. Everything abnormal. The lungs are limiting this guy a lot. And you see here the tidal volume reach the plateau. And in fact, he has oxygen desaturation here in green. And actually, we measure by transcutaneous CO2, the PCO2 that goes up. So there is hypercapnia. So you see here, there's a lot of dyspnea during submaximal exercise. And very important, look here, throughout exercise, there is extensive expiratory flow limitation. The inspiratory reserve volume is reduced. And the patient reports more and more dyspnea as the inspiratory reserve volume goes down. And you see here the trapezoid shape of the flow volume loop. Exactly what I told you. This patient has critical inspiratory constraints. These patients present with a low inspiratory reserve volume. This patient presents with dynamic hyperinflation. He reached those thresholds. There is a tidal volume plateau, and there is an acceleration of dyspnea at this point. So he reached the dyspnea threshold. So this because of the lungs. So you would make a big mistake if you have relied only on peak breathing reserve. That was clinically important because we step up for dual therapy instead of LAMA. We put on a pulmonary rehabilitation, and importantly, we show that what the lung is not the heart that was causing dyspnea in this individual. So I will be completely wrong to say that the lungs were not causing dyspnea if you have stopped on the peak breathing reserve. So don't do that, please. Otherwise, you are going to make a lot of false negatives for ventilatory limitation. Final two slides. Put everything on context for you that loves CPAP like me. So if you have a high ventilatory stress, for example, high VVO2, VCO2 have ventilatory inefficiency. So you have excessive breathing. So now, as you know, end-tidal CO2 can be caused by a high dead space or hyperventilation. You make a relationship between them. If you don't want to measure arterial CO2, you have, for example, transcutaneous CO2 or arterialized CO2. If there is both are less than 35, and there is no difference between arterial and tidal, what is causing this excessive breathing? Hyperventilation. So now you look, is this due to hypoxemia? Is this due to dysfunctional breathing, hyperventilation, or this is just excessive stimuli, usually from the cardiovascular system? However, if there is a large difference between arterial and end-tidal, arterialized and end-tidal, what's caused is dead space, and you need to learn why. So this is excessive breathing. Now, what we discussed today. If your IC goes more than 200 ml, but more important than everything, and inspiratory lung volume is a high fraction of TLC, VTIC is a high fraction of your IC, there is a VT plateau, there is expiratory flow limitation, low peak breathing reserve, but not always. There is a dyspnea inflection versus ventilation. This is mechanical impairment. This is constrained breathing. And if these both end-tidal and arterial CO2 are above 45, the difference is smaller, we'll have hypoventilation. If not, if there is a large difference between arterial and tidal, the explanation is dead space. My final slide, Herman, where I will put this in a clinical context. People always ask me, please tell me how can I translate this to clinical care. That's the key slide. Wherever here is on the left is causing excessive breathing. So CPAP will help you, perhaps on the differential diagnosis, but also to tell you that syndromically, what you need to do is to address the sources of heightened stimulation, because it's too much ventilation. On the right side is constrained breathing. What CPAP is going to do, to tell you that whatever happened, you should address the sources of lung mechanics. Those diseases here and conditions are all that called excessive ventilation. Pulmonary vascular disease, pulmonary hypertension, mild COPD, CPFF, heart failure, mild to moderate obesity, hypoxemia, anemia, primary hyperventilation, does not matter. What is important that CPAP will tell you need to decrease the ventilatory stimuli. This is the way to treat dyspnea as a treatable tratable, or potential treatable trait. And all disease here on the right causes constrained breathing. Moderate to severe COPD, other obstructive disease, moderate to severe restriction, neuromuscular disease, severe to very severe obesity, any cause of low inspiratory capacity. Ladies and gentlemen, 40 years analyzing CPAPs, every single day of my life, in complex CPAPs, I can tell you that's the most honest way to deal with dyspneic patients. How to put CPAP really to work for us to identify the cause of dyspnea. With that, I finish, and we have a little bit of time for questions.
Professor Neder, thank you very much for this dynamic and very inspiring webinar. I cannot imagine that you will not do this kind of measurements after this presentation, and I heard it a few times this year during the CPAT advanced course of ERS, and again and again. A big thank you for this very inspiring lecture. We already have a few questions. One person asked 8 questions, and I had the feeling you want to explain a little bit of, is it error issues? We also received a question. We sometimes see some drift in the signal, and I have the feeling you like to explain a little bit how you deal with this.
That's a very important question, Herman. This is quite important, and I'm going to show you what we do. So there are 2 scenarios, Herman, and everyone. One is that when you have a small drift, let's explain to you pace by pace here, step by step here. So look here, there is a drift, look here, that the signal is going up, up, and up. But the maximum recorded, the last recorded tidal volume is actually, the end inspiratory lung volume is smaller, is lower than the inspiratory capacity. So let's call this as a small drift. When you have this, what you need to do is to imagine a tangent line that goes through here, and when this tangent line reaches the end expiratory lung volume just before the inspiratory capacity, put the end expiratory lung volume line here, because now it will not consider the mistakes, the problems done before. So this is when you have a small drift. So you should drag the end expiratory lung volume line to here. But now sometimes we have nightmares like that. Look here. In this case, they have a big drift. So the last tidal volume, the last inspiratory lung volume is bigger than the inspiratory capacity. So see what the system did. The system considered this as your inspiratory capacity. So look at the huge inspiratory reserve volume you have. So there is something profoundly wrong here, because the system is considering here. But don't desperate. There is a way for you to deal with that. What you should do is the following. First of all, you should also do the same thing that you have done before, but you select that inspiratory capacity, inspiratory capacity maneuver, and pay attention, make now your maximum expiratory flow volume loop by touching here to reach the end inspiratory lung volume of that breath. So you press here in the middle, and you push this here, and make them to match here. Now the system is actually making all comparison against the right volume. Then what you need to do is actually select 2 breaths before that that now the system knows exactly how to compare. And now the inspiratory reserve volume will no longer be the distance between here and here. It will be the distance between here and here. And now you can properly identify the inspiratory reserve volume. So it is feasible. It's feasible. So if you have further doubts, please access my slides that will be available for you later. And there is this step by step. Basically, you make the system to use the right point of reference to calculate the proper inspiratory reserve volume when you have big drifts. A very important point, Herman, that I loved in the new version of the system, but this should be the new the software higher than 3.3 version, that now you guys put this button here that you can delete the inspiratory capacity that is wrong. That is important because that further help us to ensure the best possible quality. Hopefully that becomes clear.
Yeah. So we have more questions. So please, try to answer as short as possible. But I'm happy you do some application training for us. I try to find some questions, not the same question you already covered. How do you ensure proper calibration? Or which calibrations are really needed for the system to have minimized the technical errors?
Yeah, the system can actually have a very, very smart, at least the Ventus system that I know, there's a very nice way to generate different patterns of flow. Which is quite smart and interesting. I'm from the old school, so I still use the 3 liters syringe, right? I like to do that because that gives me more sense of, I learn to doing that, but I know that the Ventus actually allows you, there is an automatic way that it generates different patterns of flow. Very important. If you are using the 3 liter syringe, pay attention. Do on different speeds, please. And do calibrate on high flows as well, because that improves the detection of flow and volume when the patient has a higher exercise intensities.
Oh, I don't want to go against you, but I think you mentioned that you have to verify the different flows if you do it with the manual calibration.
You need
what
to
are the
get
key differences if you measure long volumes at rest compared to dynamic hyperinflation? So you can also have static hyperinflation, dynamic hyperinflation.
Absolutely, that's a very important question. We have done so many studies on that. What happened is, let's start from the beginning. If someone has a static hyperinflation, right? But the patient, for some reason, does not actually, the end inspiratory lung volume of this individual does not reach or get close to the total lung capacity, you are not having substantial dyspnea. Why you are doing the CPAT? You are doing the CPAT to see if the dyspnea can be explained by the lungs, by the mechanical abnormalities. The resting lung volumes, they are not highly predictive because there is a huge heterogeneity on how the tidal volume is actually put inside the inspiratory capacity. And sometimes you have patients that do have resting hyperinflation, but they are able to decrease the end expiratory lung volume at some extent, or they are able to not to increase tidal volume that much, and they protect the inspiratory reserve volume. Of course, the likelihood of you to have critical inspiratory constraints is much higher if you are hyperinflated rest, of course. But you have quite a complete heterogeneous problem, pattern. Please, the person that asked, please, look, it's not only dynamic hyperinflation, please. Dynamic hyperinflation is just a piece. What is important is the difference from the end inspiratory lung volume from TLC. The problem is on the ceiling, not on the floor. As I show you, you can have no dynamic hyperinflation, zero dynamic hyperinflation, and profound dyspnea, and profound inspiratory constraints. Depends on the distance from the ceiling.
Okay, thank you. And I think also you mentioned this a little bit, like how can we differentiate between pathological responses, like in clinical in patients, compared to the constraint in or the limitation in athletes?
Very good point. It's all about the intensity of the exercise. Actually, I didn't have time to stop. I didn't want to stop the video that you saw. On the video that you saw today, that guy reached inspiratory constraints. I don't know if you pay attention, but his tidal expiratory flow volume loop reached the flow volume. That guy is a well-trained young subject. But that was a work rate of 140%, 150%. So you can see all those abnormal things, but on a supramaximal work rate. So that means fundamentally that the individual has reached inspiratory constraints by the fact that he exercised maximally. Another point, a point about the dynamic hyperinflation. Someone asked me, are you sure that no one dynamic hyperinflate? Yes. Old subjects, females, they tend, particularly old females, they do hyperinflate a bit. This is why we use this 150 to 200 ml threshold, because up to that you may have some degree of dynamic hyperinflation. But again, despite that dynamic hyperinflation, you protect the end inspiratory lung volume. Please have a look on the European Respiratory Journal Open, published this week. We evaluated with colleagues from Germany. I see in thousands of individuals in a very large study in Pomerania. Have a look on how amazingly the respiratory system protects the inspiratory reserve volume, despite some very mild dynamic hyperinflation in older subjects.
Okay. There's somebody who explains they do the IC maneuvers at rest, warm up and early exercise, but also they wait after the maximum exercise, so straight after the peak exercise, and they wonder if this is correct.
No, it's not. We have done a study exactly on that. It's amazing how we deflate so quickly. But another point is, please don't do only at the peak. There is this wrong impression that at the peak actually is enough. I don't want to go back to the video, right? But when you access again the video, have a look on this normal subject. The last IC of him was I think was 300 less. It was so high respiratory frequency that he was unable to do a proper IC. And this guy is trained on that. So you can imagine that how we're going to overestimate a lot of the dynamic hyperinflation if you just do at the end.
But there is, of course, also the goal. So I've got to explain the reason why they made this point, because, of course, there's also a reason to protect the gas exchange measurements at maximum exercise.
Exactly.
So it's sometimes you have to struggle between IC maneuver or VO2 max. And then I remember you said then you could better do it 1 minute earlier.
I see the point. Yes, okay. If you wanted to protect, it's better if you want to have the true VO2 max or VO2 peak, it's better not to disturb the VO2 peak, right? But in this case, properly because in the respiratory arena, we are less interested in VO2 peak than cardiology, VO2 max, with exception of pulmonary hypertension, which is a good example, exception. We actually wanted to really have a better potential idea how much the patient reached the inspiratory constraints. But I agree, it's better to avoid the last few seconds.
Yeah. And the other thing is, if I understood you well, that you recommend to do this maneuver every second minute. So,
yeah.
And you also explained in our software, I think there's a reason you can show 5 moments, but is there no chance that you initiate dynamic hyperinflation by all these maneuvers? Because when you're doing IC every second minute in your obstructive patients.
Yeah, no, it's not, because when we do that, there is enough normal tidal breaths in between the inspiratory capacity. So if you actually do, for example, when you do metronome paced breathing, where you have a very high respiratory frequency, well, this is why it causes actually a dynamic hyperinflation. But if you do IC, even if every 2 minutes, there is enough breath in between the IC maneuvers to actually allow the patient to go back to this resting normal for the patient expiratory limit. It's very important to do that. I didn't discuss at all here, but there is a whole other story that actually looking at the profile, how fast you progress towards the inspiratory constraints. The dynamic inspiratory constraints is also very, very instructive. You are going to hear a lot about that in the next 2 years.
And I can imagine this question from some people. They think you do this dynamic hyperinflation measurement or these IC maneuvers in every CPAT, no matter what is the reason for it.
Yeah, this is my life. If I can tell you, Herman, how many mistakes I made in my life, because I have a clinical dyspnea of unexplained or multiple potential causes. Everyone sent to me the worst case and say, okay, you have this machine, and they have the idea that with this machine we can separate lung from the heart, and they say, okay, this dyspnea is caused by the lung or by the heart. So, as I show you today, there are two reasons for dyspnea caused by the lungs: excessive and constrained. If I don't access constrained, I'm losing 50% of my job, of my potential job. So if I don't do that, I can't understand how can someone interpret dyspnea, assess dyspnea with exercise not doing that. I cannot understand. I receive cases around the world with people saying, oh, what do you think? What do you think? I ask, did you measure IC during exercise? How did you measure? You look inspiratory reserve volume? If not, I'm sorry, my friend, but I cannot make much consideration about that.
Now we know each other this good, so I dare to ask this question. So even when somebody comes with suspected pulmonary hypertension from cardiology?
Yeah, Herman, did you see the studies from the French group? And we did as well. Amazingly, there is a subset of patients that reach inspiratory constraints with pulmonary hypertension. It has been analyzed, I don't want to bring the details, but there has been analyzed as dynamic hyperinflation, Herman. But I suspect, Herman, that it's not dynamic hyperinflation, Herman. I think it's a dynamic inspiratory muscle weakness that developed during exercise. So the patient failed to reach total lung capacity because of the dynamic inspiratory muscle weakness. We showed in thromboembolic pulmonary hypertension, very clear. And the inspiratory constraints, they do happen on a subset of individuals with pulmonary hypertension. Unfortunately, the mechanism does not seem to be dynamic hyperinflation. So there is no point for giving bronchodilators to this guy if someone is thinking about that. The point here is that there is a dynamic inspiratory muscle weakness. We underestimate a lot the importance of inspiratory muscle weakness as a source of dyspnea in these patients.
Okay. Emphysema subjects sometimes get these endobronchial valve placements. So pre and post intervention, would it be good to measure dynamic hyperinflation measurement, and what will be the significance?
Oh yeah, absolutely. This is I wrote with my colleague Dr. Dan O'Donnell a small book on lung volume dynamic hyperinflation, and we put this exactly what that person asked now. Certainly, because what we're going to see is a lower rate of development of air trapping. And it's interesting, actually, that's very interesting, actually. After the intervention, look, Herman, after the intervention, the patient gets better. So the VEMVV get higher after the intervention. So you get a completely wrong impression because you are saying, oh, the patient is more limited. The surgery did wrong for the patient. No. It's just the fact that it's going longer. The submaximal response show actually the presence of better inspiratory reserves.
Yeah, so again, you should take into account how high they come in work rate and maximum ventilation, not just comparing the values at maximum exercise to the other maximum exercise, because the exercise will be much better. This kind of thing.
Absolutely, yeah, absolutely.
And another question about pediatric CPAT. Will this reference values or these cutoff values, you said something about percentage change or?
No, that's a very, if that person that is asking is a researcher or this is a completely open for research. Big gap. We don't know, have no idea, right? No idea. In some, where thinking to start a study with cystic fibrosis. And we need normal values for this in young kids, right? Doing the IC in kids, let's see how can we do that, right? Probably we need some animation or something like that, as we do in C. So I'm optimistic that in children over 10 to 12 years of age, we can have good ones, but we need to prove that.
I read here the question. I just read it for you. Should we use post-exercise maximum flow volume curve rather than the pre-exercise to account exercise bronchodilation to get accurate and expiratory lung volume related to and expiratory lung volume values? If so,
Yes.
how?
Yes, good point. I don't know if the central suite allows that. I don't think so. But anyway, that's a good point. The question is, because there is some bronchodilation during exercise, the pre-exercise maximum flow volume loop is an underestimation of the true maximum flow volume loop that the patient is facing during exercise, the true limits. So doing a post-exercise flow volume loop, provided that the patient does not have exercise-induced asthma, will actually give you a better way. Another way to do is, but this is research, is when you do partial maximal flow volume loops. So you don't compress the airways too much. But I don't think that's critical. I hope you guys got the point that I did not stress that much the expiratory flow limitation part. I think it's important to show because that explains dynamic hyperinflation, explains other things, but the key point is the lung volumes, actually.
I'm looking, yeah, we still a few questions, so I think we will take another 5 minutes.
Sure.
They speaking about the Jaeger CPAP usually takes the nitrogen washout for volumes, but I think it depends on if you have a body box or nitrogen washout. Yes. Do you recommend every patient to get it prior? So I think it's more the question, do you really need end expiratory lung volume as an absolute value, or can you do without absolute
No,
lung volumes?
yeah, we don't need in absolute value. That's a very good point, Herman. What that value means, right, in absolute. Now, which is important is the ratio, right? It's amazing. We have discussed it with my colleagues as well. That demand capacity imbalance is the most beautiful thing in physiology because amazingly, the system knows, don't ask me how, but the system knows what is our ceiling. It's always regulating the demand to stay a good distance from the ceiling. So what is important is the ratio. I don't think you need actually to have, but I'm concerned, for example, if you have hyperinflation, total lung capacity like 140% predicted, and you use the predicted total lung capacity, you may eventually potentially underestimate the inspiratory constraints. So when we actually are really interested in that, we have lung volumes measured before in such a way that you have the proper residual volume and the proper total lung capacity.
Oh, there's also a question, and I think you touched this subject, about the plot showing dyspnea in relation to Bohr scores or RPA scores. Can you explain a little bit more? I think you score RPA against ventilation and to work to distinguish.
Exactly. Yeah. Please look at the ERJ. I think it's 2021. The title is A Frame of Reference to Assess Exertional Dyspnea During Incremental CPAP. And you are going to see there. It's over there. Everything is there. I'm going to show to you. It's a little bit back here. What you are going to see there, here, we have normal values. These are the 5th centile, 25th, 5th, 75th centile, and the upper limits of normal as a function of ventilation, as a function of work rate is there, is an Excel sheet, and you can plot this. We're still not available this in most commercially available systems so far, but this probably will be incorporated in the future. So in such a way that when you plot this, actually, just for the person that asked me, we have now normal values for the end inspiratory lung volume TLC and VTIC as a function of ventilation in men and women. So this is also available for potential future incorporation on commercially available CPAP. What it is not done is there available, as I told you, particularly in dyspnea, on this paper that we published in 2021 on the European Respiratory Journal.
A question about, I think, measuring military personnel, so healthy subjects. Should the person be disappointed if they don't reach a VT plateau? I like the question.
That's a very, very important. That is interesting, right? Because it's the other way, right? To think about. Yeah, yeah. Well, this VT plateau is so interesting because some people that are actually watching this are working with me in research exactly that. We are always thinking about the VT plateau. You know, just pay a little bit of attention on this VT plateau. That's a great question because there is sometimes this VT plateau is reached not because the critical inspiratory constraints. We discover that this plateau may happen in normal individuals after the respiratory compensation point to lactacidosis. The second threshold, not the first threshold, the second threshold, after the isocapnic buffering. When you cross that threshold, the drive to breathe is too high and you become too very high respiratory frequency that you may have a plateau. Let me put here. It's probably on the here, right? The VT plateau. So please, this is like the anaerobic threshold. It's like the ventilatory threshold. It's not just one variable, several variables together. Please don't say every time that you see a VT plateau, you say, oh, the lungs are limited, this is inspiratory constraints. Please, please, it's not that. When this happens in association with a high-end inspiratory lung volume TLC above the threshold, a VTIC above the threshold, okay, and dyspnea goes up, okay, that is the dyspnea threshold, okay? But this may occur in completely normal subjects after the respiratory compensation point for lactacidosis, the second threshold.
So we have to finish. I I will find two other questions. I think one of them, should we, or is it only possible to measure these IC maneuvers on a bike? And I assume, can it also be done on a treadmill?
Yeah, we have done some studies on that. I don't know who is asking, but actually there is more variability on the measurement. Very good point. And there is a very interesting aspect. The decrease of the end expiratory lung volume, which is very crucial, as you saw, is very important when you are seated. That put our abdominal muscles on a mechanical advantage to deflate the end expiratory lung volume and allows the IC. So the IC goes higher, you have higher IC on a bike, actually, compared to treadmill. When you do it iso ventilation, right, on the same level of ventilation, right? No, but on a treadmill, you have more ventilation, right? Yes, it can be done, needs a little bit more training. And I strongly suggest you to make a good rehearsal with that individual, but prepare yourself that you are going to see more drift. But you can actually correct this later. The same criteria used for the IC, right? That decrease of the 200 ml or 150 or 10 or 15% from the baseline. But can be done, a little bit more work.
I already apologize. We cannot answer all the questions due to time constraints. We are already 20 minutes over. Last question, and I received it, or especially doing this kind of trainings myself, there's always the question like performing the spirometry flow volume curve like on a PFD system and not on the bike with a CPAP system. So do you expect big impact? Or should we always do it with the system which also measuring the volume measurements during the CPAP?
Yeah, that's a very good, interesting question. There are no systematic studies doing that, right? But just, I'm going to tell my experience. I noticed that when the spirometry is done on the bike, I don't know if the technician does not push the patient to the really maximum, or because of the patient is on different body posture, sometimes there is some underestimation of the FVC when you are doing seated on the bike, right? Anyway, but what we do is actually the patient already seated on the bike, right? But just to be sure if that is really well done, right? I have an idea that most technicians think that you don't need to do really a maximum good spirometry, just something. No, should be done properly.
So ideally in the same, I think it's also more the posture. So you also have the semi, what is it, recumbent bikes.
Yeah, exactly.
So the posture is maybe more important than the device. But
Absolutely.
again, okay, a big thank you. We are already 20 minutes over, and it could be that we ask Professor Neder, Alberto again. And then you cannot cover everything in 1 hour or 1.5 hours. I suppose you can speak about this topic for one day. Thank you also for all the participants who are still on the call, and these are a lot, I can see, still more than 340. And I'm encourage you, I think we will not have any webinars anymore before the end of the year, but we are trying to plan more of this kind of webinars with PFT or CPAT topics next year. Thank you.
Yeah, thank you very much. And Herman, if I could give a final message, is the fact that all my interest and all the clinical impact that this happened was the fact that we, as respirologists or pulmonologists or someone that work with patient shortness of breath, use CPAT to answer the question that whether this is why this happened, if we can provide proper explanations and what we can do to help, potentially help the patients. So hopefully you got the point today that on this framework of excessive breathing, constrained breathing, and in many circumstances, what we can do more actually therapeutically is on the constrained breathing, is very important for us to identify that. That will also make us to make much less mistakes. Thank you very much for the invitation, Herman. And I was, again, congratulate you for this initiative. There's not a lot of people talking about this around the world. And I think this is a very important topic to be more properly discussed. Thank you for the invitation. And bye-bye to everyone.
Thank you.
Thank you.
Bye.
Bye-bye.